Okay, so a couple things we left out on stroke. Some terminology that you might need is dysphagia. Okay. I don't know if we've come across that word. Dysphagia. Everybody knows that, right? What's that? Difficulty. What do you think that is? Huh? Speaking. How did you know that? Huh? Yeah. So the way that I remember that is sort of crazy. A phaser. I don't know. I get these crazy things in my head, but phasia, speaking. So difficulty speaking in our FAST protocol that we use to determine stroke. We use speech, the S, right? Yes, for speech, difficulty speaking. Okay? And phasic, aphagia, A means what?
Is it DYS?
Yes.
Oh. Yeah. There we go. Better? Okay. So, aphagia, A means inability without, right? Phagia,
Cannot speak.
eating, right? Eating. So difficulties for swallowing, perhaps, in this. So, aphagia, phagia, polyphagia, poly meaning many. We're about to get into that. Polyphagia, one of the 3 P's of diabetes, right? So, we get into the terms here. The other stroke scales, because I mentioned, hey, there's a lot of different stroke scales. The ones that you're going to hear the names of, and I can't remember that hospital scale. It's like it has to be NH something. It's hospital, national hospital, something stroke scale, right? Again, slacking, I should have looked that up. But anyway, it's very lengthy, like we were talking about. They do all sorts of different tests. We had a coach stroke come in yesterday, and so they went through this test, and they were doing all these different tests. And but we don't sort of keep it simpler, okay? And just so when you hear the names, you go, oh yeah, that's that stroke scale. And there are different stroke scales. The Cincinnati stroke scale, which involves the facial droop and the arm drift, it sort of aligns up with the FAST, okay? And then the LA stroke scale. They just put different components in there. And the reason they're named after Cincinnati or LA, who knows? I mean, maybe a hospital in Cincinnati came up with it. Just like when the last 6 weeks when we talk about burns, Parkland burn formula for fluid resuscitation, I guess Parkland came up with that, so they named it after themselves. So anyway, just for your general knowledge and trivia, those are just different stroke scales with different types of tests to determine if they could be having a stroke. And they're based on these signs and symptoms, so you can think, okay, grip strength, right? Weak grips, so that's part of somebody's stroke scale. They test different cranial nerves by sticking the tongue out, touching the nose, right? You see them in the hospital, the patient will touch, almost like a sobriety test, right? So they'll touch their nose, and then the doctor will ask them to touch their finger, they'll hold their finger up, the patient will touch their finger. Okay. So another thing that sort of mimics the stroke is, hold a moment, Bell's palsy. Okay, somebody Google that for me right quick. The Bell's palsy, and it does mimic stroke because it causes slurred speech. It causes sort of a droop in the face. Okay, and a lot of times people have that, forget that, and they think, oh no, we're having a stroke, but they go through these tests, and they say, no, this is not a stroke. So somebody help me out with that.
The definition of it?
Yeah.
Sudden weakness in the muscles on one half of the face.
Right. So they get the weakness in here, but what it doesn't do, it doesn't affect the extremities, right? So when they do the test on the extremities, they sort of limit that and go, well, hey, there's no effect to the extremities. Now, depending on the doctor, they will still do their work, and they'll probably CT their head just to make sure that they're not having a bleed, right? It may seem like a unnecessary test, but in the land of litigation, and you have to cover every base. You know, they do a lot of unnecessary tests in medicine to cover every base, just in case, because you know if the patient was there and they said, nah, this is probably not a stroke and it's not a bleed or whatever, and they didn't do it and they had a bleed, don't you imagine that they go to court over that? You know, even if it was an honest mistake, they would still go to court. Families would still probably enter into litigation. Almost everybody would. You know, and that's the cause of these unnecessary medical tests, right? That's the beauty about medicine in the military. That doesn't happen, you know. But anyway, and this is something else I left out as well. TIA, you probably hear that. It's very common with the stroke, transit ischemic attack. What does transit mean? If you have someone that's a transient, is that a word? Yeah, they move. They're like a gypsy. They move, they stay for a little bit, and then they move on. They stay for a little bit, move on. If they're a gypsy, they stay for a little bit, they rob everybody, and they move on. So, according to TV, I mean, I don't know any gypsies. So, a TIA will, all of a sudden, this patient will have these signs and symptoms of a stroke, okay? And they're thinking, okay, they have a stroke, but like it says, within an hour or some time, usually within an hour or a little time, this resolves itself, okay? And then all the signs and symptoms go away. It could or could not be a precursor to a stroke, or, you know, regular CVA, but the signs and symptoms will go away. One of the most costly TIAs I've ever encountered, not for me, but for the patient, I guess, is that it was put in between Dallas and everything, so it was quite a lengthy drive to go into Dallas with the patient. Anyway, this EMS crew thought that the patient was having a stroke, so they launched us in a helicopter, and we came out to pick up the patient and fly them to Dallas, which is appropriate care where they were located and where they needed to go, because the fact that we could go 150 miles an hour without stop signs, okay, and we could fly them and get the appropriate treatment, because time is tissue, and so that everything was appropriate. So we get the patient, it looks like the patient is having a stroke, we do all of our tests, like, okay, we're going to the stroke center, get on the helicopter, take off, start heading towards Dallas, and then all of the signs and symptoms went away. Time we landed, the patient was absolutely normal. No signs and symptoms, so she had a TIA, right? About a $15,000 TIA. Because that's usually the price of a helicopter ride, medical helicopter ride. That's if we don't do anything at all, except give them a ride, like we did here. We didn't do anything to the patient. We didn't have to. Just put them back on oxygen and took them, right? The crew did everything. So we didn't really give any medicine. We didn't do anything. About 15 grand. If you had to do something, of course the price goes up. You're looking at $20,000-$30,000. Yeah. So it's pricey. But like I tell people, it's say if you're dying, your life is worth $30,000.
Let me die.
Yeah. But anyway, so the transient ischemic attack, TIA, it will look like a stroke, it'll smell like a stroke. It's just not a stroke. These are going to resolve. They'll do tests to make sure that they don't have any blockage, or do the MRI to make sure they're not having a ischemic stroke, and do different studies to see where the blockages are, perhaps. Okay. So do the fast, like we talked about. Do the fast. Do in your assessment. Do a complete assessment. Sample OPQRST. Really help the patient there. Protect if there's an affected side, protect the affected side, and do like signs and symptoms, treatment. Okay, treatment is mainly supportive, unless you're the neurologist. And then if you're the neurologist, then you would go in, and interventional neurologist, you would go up, find that clot, pull it back out, extract it, or give the TPA or what old moment, but I never had a TPA. Adivase or clot buster, right? In there. So,
Randy, why does the TIA occur?
the same, but blockage. It occurs the same part. They have sort of a temporary blockage in there. It just resolves itself. Maybe the clot busts up. So let's move on to diabetes, diabetic emergencies. Okay. Did you watch this video? Did I have watched the Krebs cycle? Okay. You can thank me now that we're not going really too far into the Krebs cycle. All right. It gets into a lot of biochemistry. You will go into this in anatomy and physiology too, probably, or if you're going in the medicine route, you'll go in biochem. You start looking at this, but it really gets too much for us. But I want you to have a general understanding of it. We're just not going to flush it all. I do want you to have a general understanding of how it works. So you take this glucose molecule 1, and like Con said, it's a 6-carbon molecule, and it goes through the process of glycolysis. I have to say that slow.
Glycolysis.
Glycolysis?
Yeah.
Glycolysis, right? Or if you're in Texas, you sort of just glycolysis. Glycolysis. Anyway, this ending here, the LYSIS on this, okay, means to lyse. So when you see that suffix, you know that it's lysing, or it's splitting that apart, whatever it is. Okay, it's splitting it apart. So what it does is it takes this 6-carbon molecule and it goes through the pyruvic cycle. Maybe, I don't know if that's what it's really called, but it splits that glucose molecule into 2 3-carbon molecules, pyruvic acid, right? That sound familiar? And then it goes through the oxidation phase, which they're saying some people add this into the Krebs cycle, the citric acid cycle, some people don't. Then once it leaves that, it starts producing CO2 and these NADHs and NAHs and all this, okay? I copied this online so you'll just know what that means. How would you say that?
Nickel to the nine.
Any questions while we use abbreviations? Yeah. Anyway, what is a cofactor found in living cells, the compound, blah blah blah, because it consists of two nucleotides joining through the phosphate groups, yada 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 yada, right? And anyway, just a bunch of biochemistry, and then you look at it in the chemical structure, you know, and you go, okay. But if you don't have organic chemistry behind your biochem, you don't understand it. So we just go with it's the NADH or the NAD, whatever. It starts to break this molecule down, okay, through this acetyl-CoA cycle. And then it enters, once it goes through there, it enters the citric acid cycle. And in your college level anatomies, what you would have to do, you would have to memorize this. And not only memorize it, but you have to know these different functions. But that's for later, okay? Because I try to stay away from things that give me a headache, and this is one of them. The renal system and this gives me a headache, so I stay away from it. So, but when it enters this, it starts to oxidize these. It is important to remember that it sort of, what word did he use? Cleaves off, or it branches off a CO2, so it produces carbon dioxide. And more importantly, what does it produce? ATP. So each turn produces so many ATPs, right? What is it? 38? Is that one turn? Okay, so one turn produces 38 ATPs?
Yeah, one turn. It's either 34 or 38.
Yeah, one of those. Okay? So it produces the amount of ATP we need for what? Energy for the cell, right? Without ATP, we have no gas. Okay? So we need oxygen and glucose to do this. Okay? If we don't have oxygen and glucose, this doesn't really happen the normal way it should. It still will happen, or we won't have life, because we won't have any ATP, any gas, right? So, but it will work differently. Like in diabetic ketoacidosis, we start burning these fatty acids, okay, and then it burns a different way. It is not healthy to burn fatty acids. You know, it's just an alternate way of burning the fat, but it's not the way to do it. So anyhow, so we run into this, and this is a continuous deal. As we are, if the healthy people that have this, then this happens all the time. We're producing this ATP all the time, and going through this cycle all the time. Metabolism of this glucose is quite complicated, as you can sort of see. And I mean, we're not even scratching the surface of it. We're just sort of doing a flyby on the Krebs cycle and the ATP. It's very complicated once you get in it, and it all happens in this little matrix, right? What part of the cell produces? It's the powerhouse produces the yeah. So yeah. Anyhow, so be thankful for abbreviations, and be thankful that we're not in biochem, but it does produce what's desired through here, and then problems that we have are going to produce. They're not going to produce this the way that it normally does. Right? Oh, that's sort of a mess. Let's come back to this. Okay, so diabetes. What? No, I want to go here. Okay, back here. So the pancreas is responsible for the production of insulin. Okay, and in that production of insulin, it's off the islet of Langerhans. Okay, it's actually where it's at. If you want to get really detailed about it, it's not on the pancreas. It's like our skull is on Cartwright, right? But it's 3300 Cartwright. So we know that the pancreas is the organ that produces glucose, right? But the exact place is on the islets of Langerhans. Now, the pancreas is also responsible for normal digestion, right? As well. So we have when we talk about diabetics, we have a type 1, or it's a type 1. They produce either very little insulin or no insulin. All right. So if they produce no insulin, what do they have to take? Insulin. They have to inject insulin, because when we start looking at this cell, we'll sort of expand that a little bit more. And then the type 2 diabetics, this is all off of the video, right? This should sound familiar to you. So the type 2 diabetics, they have these damaged receptors. This beautiful drawing here sort of lays that out for you. But these damaged receptors, either they have to increase the sensitivity, or they may have to have more insulin, or they might have to change their diet. A lot of times, I've known a lot of type 2 diabetics that change their diet, and it resolved this problem. But some have to go ahead and take insulin, some doesn't, okay? The normal blood glucose level, we went with 80 to 120, right? But some books will say 70 to 120. So 70, 80 to 120 is the normal blood glucose level. So glucose entering in the cell is called, it has to go by an active transport. So it has to have, an active transport means that it has to have help getting into the cell. It just can't come into the cell itself. The easy way to explain this is insulin is the key that unlocks the cell. Okay? That is very basic, but it's true. It doesn't necessarily unlock the cell, but it allows the insulin to enter the cell. That's what the function of insulin is. It allows the glucose to enter the cell. It opens up channels, okay? Different channels. These cells have different channels. Some channels are voltage gated, means that they have to have a certain voltage to open up the channels. Other channels open due to pressure and different things, okay? So this cell here essentially opens this channel, okay? Once it meets in the receptor site. See, we have the receptor site here. This is the normal one. So you have this insulin molecule, or it's a hormone actually, right? So you have this hormone, and then you have this receptor. On each cell, there's like a gazillion receptors. And it just measures different functions. It would be like you go on a trip out in the country and you see this mountain with all these antennas on it. So there's all these antennas measuring these different functions. So once the insulin meets up with this receptor, it opens the channel. That's the normal. So it's the active transport. What happens is in type 2 diabetes, okay, is there's something wrong with the receptor. It's all jacked up, right? Look at that. This insulin comes over here, so I can't fit there. I'm not going in there. And so if a lot of these receptors are damaged, okay, then the cell is not going to meet up over here. Doesn't mean every cell is damaged, just means some are damaged. So they may have to take more insulin to increase the sensitivity here, or change their diet. but that's sort of the type 2 diabetes here, and type 1. Type 1 is just that they don't have the insulin. Okay, so that's easy to understand. They give them some insulin, right? The other one is the type 2. So when we look here, when we look at this magnificent picture, okay, what takes place in the liver is we have glucagon, okay.
60% discount.
What?
You get Fight Fence Pro at 60% discount. Yeah.
What'd you say?
I was reading what it said.
What does it say?
Oh, we just deleted it.
Oh, okay. Was it important? Maybe I shouldn't have deleted it. Maybe we should go shopping instead. Glucagon is converted to glycogen, and we don't really need to know this except this pathway. Okay, glucagon is converted to glycogen, and glycogen is converted to glucose. It does this when there's a decreased level of glucose. So if you have that third lunch and you don't have any snack, right, and by 1:30 in the afternoon, it's time to eat, right? Especially you guys don't eat breakfast. So it's time to eat. So the body recognizes here, hey, I'm sort of low on glucose. We need glucose for proper cell function, correct? So I'm a little low on glucose. So I'm going to tell the liver to convert this glucagon to glycogen, which is going to convert it to glucose. And then we have sort of a stored amount of glucose, okay? The other one is, on the sympathetic side, it releases epinephrine, and one function of epinephrine is it stops the release of insulin. So it's going to increase the blood glucose. Right? So if the body recognizes, hey, I'm low on glucose, I'm low on gas, right? Same way with your phones. When you get low on battery, you start shutting everything down. You go in that low power mode, right? All right. So the body, once it recognizes this, it will release epinephrine from the adrenal cortexes on the top of the kidneys, right? And it will, epinephrine is going to stop the release of insulin and increase blood glucose. What else is the epinephrine going to do? I can't hear you. Increase heart rate. Yeah. It's part of the sympathetic nervous system, so it's going to decrease heart rate. Epinephrine will also slow down the gut, and so you're going to decrease motility and digestion, which is also going to help with blood sugar, right? And it's just doing this to maintain what? Homeostasis, right? So when we look at the diabetic type of emergencies, we have the three common types. Okay, we have hypoglycemia, which is hypo low, hyper above. So someone hyperglycemic is above 120, but they're well above 120, right? 125, you're not really hyperglycemic. I mean, you are by definition, but it's nothing to worry about. 200, yes, there's a problem. Okay? So, and then you have DKA, diabetic ketoacidosis, and this is where the body starts burning those fatty acids and producing the ketones and making the body acidic. The pH drops off and becomes acidic. We have the 3 P's of diabetes, which we'll go through in a minute. Polyuria, which would mean what? Many urine, if you take it literally, or excessive urination. Okay. many urine, so excessive urination. Polydipsia, a new word. Dipsia.
There's an I.
Huh?
There's an I somewhere.
Where?
After S, I think.
Oh, yeah. Polydipsia. Dipsia would mean what? Think about back in the day. How did they get their water? Yeah, excessive thirst. They dip water out of the well. So polydipsia, excessive thirst, and then polyphagia, excessive hunger. Okay, so the way that these three P's come about is polyuria, excessive urination. They're trying to get rid of the ketones and stuff, so they're doing it through urination. So if you have polyuria, what else would you have? Very good, dehydration. Okay, so then the excessive thirst, and so this is one way that they adjust the excessive urination. It's adjusting, the body's adjusting, using the renal system to adjust to get rid of the excess glucose. This Kussmaul, and I say that Kussmaul because I went like over a decade mispronouncing that word. I was putting an H in it for like 15 years, okay, until someone corrected me. But it's Kussmaul. I have a video, so that'll speak 1,000 words, but it's deep, fast respirations. Kussmaul respirations are deep and fast because in DKA, or someone with Kussmaul respirations, they're trying to blow off the CO2 and to rebalance the acidity. Okay, so it causes deep, fast respirations. And then also with DKA, because of these ketones, you get that fruity odor smell. It's almost like a bourbon. You know what I'm talking about? Oh. You smelled bourbon before? Bourbon has this sweet smell to it, and so it produces this acetone type smell, or this bourbon type smell, which really back in the day you had this person that was disoriented, sort of slurred speech, stumbling around, and Charlie the cop came up, and what do they think? They're drunk. Okay, and so they put Danny the diabetic in jail in the drunk tank, and the next day they'd go release him to go home, and he would be dead because he had diabetic emergency. They were diabetic. They didn't know it way back in the day. They didn't know this. Now, what they will do is if they suspect the person having diabetes, they'll do a D-stick. Can't tell you how many times in the morning that I woke up, they woke me up for a police stop. The person is in the back of the police car saying that he's a diabetic. That's why he's talking like and looking like he's drunk, and he's handcuffed here. And I go get a finger, do a D-stick, normal D-stick, off to jail. Abnormal D-stick, coming with us. So fixes that really quick. And usually I tell them, I said, man, if you're not diabetic, just tell them the truth, because in 10 seconds we're going to know, and it will save you sort of a painful stick in the finger. No, man, I'm a diabetic. Okay. Nope. Nope. Then you have this other thing called hyperosmolality. I'll have to look at the word that didn't come up to pronounce it, but it's the old definition is called HINC. Okay, we'll get to that in a minute. And anyway, that's where the blood glucose level was like 700 to 1200. It was extraordinarily high, and it dealt with the movement of fluids. Okay, not DKA, but it's just the movement of fluids. You had glucose in the urine, which once the sugar starts passing through the urine, which is completely abnormal, it draws fluid through it. Remember, I think we talked about it being hypertonic, and it will draw the fluid. With sugar or glucose in the urine, it will draw the fluid out because it comes in sort of this hypertonic state. Okay, I think we covered that. Just when we intake glucose, the body was at 30 to minutes or so. It's going to release insulin. That's why when you eat lunch and you come to your class after lunch, you get all sleepy, right? Everybody gets sleepy. They go, man, why can't I stay awake? It's because this insulin dumps in there, and it makes you sleepy. Everybody gets that way. That's why, one of the reasons why I eat a light lunch. And a protein lunch, not a big carbohydrate lunch, right? Because you put on all those, you eat that 2 or 3 pieces of pizza for lunch, that high carb, you're going to get sleepy. Right? If you do sort of a protein type thing in a light lunch, low carbs, you won't get as sleepy. Okay, so and you still have plenty of energy. It doesn't decrease your energy. Okay, so let's look at it. So we know that insulin helps transport the glucose into the cell, and then the diabetes affects either the insulin or the ability for the insulin to work. We have hyperglycemia, and this is, underline this because this is very important. Hyperglycemia is a gradual onset. It could take days for this to take place. All right. Some of the reasons being is they're not taking enough insulin. Maybe they're a diabetic and they're not taking their insulin correct. We call them a non-compliant diabetic. Okay, or they eat too much. Instead of eating, a couple of scoops of blue, they go all out and eat the whole time. Right? And boom, there goes their blood sugar out of control. So they get hyperglycemic, hypoglycemic. Underline this word, it's a sudden event. So they could take too much insulin. Insulin is very regulated, okay? When they give it, it's measured in units, so it's very regulated. Or they eat too little. They overexert without eating, okay? Or they get sickness. They get something where they're vomiting and they're losing fluid and they're losing food through vomiting. So that's another reason they can get hypoglycemic. Now, everybody can get hypoglycemic. You don't have to be a diabetic to get hypoglycemic. If I waited till 2 o'clock in the afternoon to eat, check my blood sugar, boom, I'd probably be a little hypoglycemic. You can tell that the person's hypoglycemic by one thing they get really, really quick when the blood sugar drops. They get a headache. Start getting a little headache. Then they get nauseated, little nausea, not a lot. Like if you wanted to judge it, maybe a 2, right? Of nausea. You're not going to throw up. You just don't. It goes to that. I just don't feel right. I get nausea. Then what do they get? Now, it's on Snickers commercial. Hangry. Right. Get a little hangry. Is that the way you pronounce that?
Yeah.
Hangry? Yeah. It's time for something to eat. Because they get a little irritable. It's people are just hypoglycemic, not diabetic. All of a sudden they're easy-go-lucky, and you you reach over and talk to him, and he's like, "Oh, you cut your hair." "Yeah, I got my hair. What about it?"
I'm sorry.
You need a Snickers bar? Remember the commercial? They're all mean, and then they eat the Snickers bar, and they go back to whatever it was. Yeah. Okay. Yeah, the Brady Bunch. Yeah, that's funny. So you have these two. These are the two big ones here. Remember, days, gradual event, sudden onset. Okay, so you can picture this, how this person would look. This person out there, the diabetic, they're doing some sort of activity like playing football or track or something, and they're really exerting themselves, and they're burning a lot of glucose. So that could be a problem, and it is a problem. When you take exams, you burn a lot of glucose. So that's why on exam day you need to make sure that you're hyperglycemic. You need to up your glucose intake well before the test, because you want to up your glucose intake and then have the insulin dump, and then so don't drink 23 flavors in a Snickers bar right before. You got to give that insulin some time to kick in. You're going to get sleepy during your test, right? But up the glucose. You burn a lot of glucose. So signs and symptoms of hyperglycemia: abnormal breathing, that fast, deep breathing, hyperventilation, the warm to dry skin, the fruity odor that we talked about. They're burning these ketones. In the hospital setting, if we have this, we get a hyperglycemic patient in there, we'll try to bring as many patients in there and or you guys in there, and for this patient, and just take a breath. Oh yeah. And just breathe in, and that way you know that. So you get familiar with that smell, sort of like a GI bleed. Once you smell a GI bleed, you will always know the patient has a GI bleed. Okay? All you have to do is smell it. Go, yep, that's a GI bleed. Then you go into the room and you smell ketones. They're burning these fatty acids, and you go, yep, they're hyperglycemic. You know that for sure. Okay? And then down to unresponsiveness. So the ultimate treatment for this is to do a good physical exam, try to figure out why the patient's unresponsive, or try to figure out why the patient has these. And then the ultimate thing that they need is what? Well, if they're hyper, insulin, right. So they need insulin, okay? If they're acidic, then they need, they could need bicarbonate, right? So what you do if you don't have your, you don't have a glucometer, you don't know if the patient's hyper or hypoglycemic. What do you do? What do you want to do? Which one do you want to treat? Hypo, right? Because the small amount of glucose or sugar that you're going to give them won't make any difference if they're hyper. If they're hypo, it will make a huge amount of difference, right? And I was sitting in, when I used to eat in the teacher's lounge, I was sitting in the teacher's lounge, and this rather large sub came in, and she looked bad. General first impression, she sat down at the same table, and I looked over and I'm like, "Are you okay? You don't look so good." And she goes, "Yeah, I'm a diabetic. I need to eat." So she had a sandwich, right? She's going to eat this sandwich, and I said, I think you need something a little faster than that. Do you have orange juice? Do you have something in your lunch pail there that can absorb a little faster? That sandwich, like a candy bar, is going to take some time to break down. You need more of an instant glucose, right? Oh no. So, being the good person that I was, or am, right, I took my dollar bill and went over there and got her a Coke. Non-diet, real Coke. Right? Was it because I'm so nice, or did I have an alternative motive? No, I really had an alternative motive. I didn't want to have to pick her up if she passed out. so so we went over and got her a Coke. I said, here, take this Coke. It's fizzy, but hold it in your mouth as long as you can, and because the sublingual tissue will absorb that. The diabetic, the person that's hypoglycemic, will absorb that fast. The body needs it, so it's going to try to absorb it fast. Okay? And then she her color sort of came back, and I'm like, oh, you look better. Now I'm going to take the rest of my lunch and go away. So, but anyway, so err, if there's a question, err on the side of hypoglycemia instead of hyperglycemia. Okay. So we look at the hypo, dizziness, fast in onset, if excessive hunger. You get down in here and they start having seizures, okay? You need to treat the hypoglycemia. This is why you run up on this patient, like the test, like Quay said, you have that patient with sudden unresponsiveness. What do? You have this patient that is doing well, isolated ankle injury, I think the question was, and then all of a sudden went from boom. Check the blood glucose level, right? Because what's the rule? Or the D-stick, yeah, what's the rule? Yeah, any altered mental status, do a D-stick. Did that patient suddenly have an altered mental status? Yeah, they became unresponsive. So they had an altered mental status, so do a check the blood glucose. So here you would do what? You would, if they're having a seizure, you do a D-stick, and their D-stick is extremely low. You treat the seizure, which we don't know how to do yet, or you treat the low blood sugar. Low blood sugar. So you would give them potentially glucose, D50 or something. All right, we'll speak of it in a minute. Okay, so check the blood glucose. Evaluate the need for oxygen. Just remember here, hey, this takes a little bit of time. Okay, so you wouldn't want to give them you definitely wouldn't want to give them hard candy if you thought they would pass out, because then you could have a what? Choke. They could have they could have an airway obstruction. Okay. So that's hypo. It's pretty easy. Diabetic type things are fairly easy. Okay, and then too small.
Breathing. This is Guzman breathing. This is the breathing that you see with diabetic ketoacidosis. He's a little bit altered. He's a little bit slow to wake up. So he's pretty severe. He has some weight loss, and then he's having some vomiting. No, this is new. This is brand new. He's had no prior documentation for diagnosis of PKA or diabetes. I smell little kid guys. Yeah.
Yeah. So anyway, they took video just showing us what it looks like, because sight and smell it helps us remember, helps us recall. So we smell that ketones, then all this stuff about ketoacidosis should come flooding back to you, with the smell. You see that. So it's very important to understand. Now here, when we talk about ketoacidosis, one thing of ketoacidosis, it builds up over a week period. And a lot of times they get ketoacidosis because of the fact that they're sick. They have some sort of infection or they get sick, okay? So here we have the CO2, 35 to 45. We spoke about metabolic and respiratory acidosis a little while back, right? Help me to remember.
Yeah.
Okay. So what takes place they will draw a lactate on this patient. It's the green top that they put in the ice. They may say, go get me a cup of ice, and they draw some lab and they put that in the ice. They draw lactate for lactic acid. Okay? And then they start looking at another thing that they will look at is the urea or creatine function, the kidney function. Okay, and when they start trying to diagnose DKA. So just a reminder, normal CO2 35 to 45, right? And the pH 7.35 to 4.5. The acidity goes this way, okay? The alkalosis will go this way. And it also affects the potassium levels with the urination. Excessive urination, potassium will go with it. So we have excess lactate from the pyruvic, which would lead to DKA. And I'm not exactly sure. Get this fatty acid breakdown. It starts in this beta oxygenation, which is nothing to remember, but this catabolic process. Catabolic, when you hear that, it's a breakdown. So it starts to break down these different processes. All right? And then this is where we get to where it breaks down into smaller units or smaller molecules. I'm sure I had that up there for a bigger reason, but I can't remember now. So anyhow, so just a little review on that. Because diabetic ketoacidosis, you have the problem with the acidity, and then you have the problem with the increased blood sugar level as well. Doesn't look that like butter?
No.
Little, like right there. Egg. Like, looks like what? Kolache, yeah. A little kolache with mustard on it. Yeah.
You're right.
Next time we go, we'll get donuts instead of McDonald's, and we'll get a kolache with a little mustard on it. And it sticks out. Remember, the little toe sticks out with the red. Put a little mustard on it. Diabetic toe. Anyway, what happens here? We get these non-compliant diabetics or diabetics that are having, they're having problems controlling their blood sugar. And what it does, I think it mentioned it in one of the videos, the microcirculation. So it gets down to the capillaries, right? And this excessive sugar intake causes this, excessive sugar in these vessels, which hardens that vessel, correct? And decreases blood flow. So you clog that vessel up with excessive glucose, and now blood supply can't get through, okay? And then you get the diabetic toes, okay? And it also affects the vision. So you get diabetic patients who are non-compliant or where they can't regulate, and their vision goes. They start having to amputate their toes and their feet, their legs, right? And so you recognize that really quick. This person here would have to enter into a field of medicine called wound care. And they would take this and try to heal this, which takes a lot of time. and it's very painful for the patient, okay, to have these things. This is bordering on losing these toes, okay. So it's just a special field of medicine. Maybe you'll see this, maybe you won't, okay. But you get into the diabetic because of the sort of the clogging up, I guess you could say, of that microcirculation, and then they start losing circulation in the smaller areas of the body. Diabetic neuropathy is what it's called. Anyway, it causes nerve damage. You have the diabetic, you see on the commercials, you have the diabetic feet, when it sort of hurts, it tingles. So it causes nerve damage because these nerves now are not getting circulation because those microvessels are clogged up. So nerves need blood flow. So the TED hoses, we'll learn about that on Friday. Diabetic socks help compress that and help with circulation. If you're not a diabetic, they make your feet go numb. I found that out, by the way, through a little process. Okay, so it causes this peripheral artery disease. That's really the gist that you need to know. I put a lot about up there. We'll talk a lot about this when we talk about the TED hoses and compression vessels and everything. So this is all just FYI information for you, okay? So everybody good? Hypoglycemia, DKA.
So hyperglycemia leads to diabetic toes, or
Hyper. Too much.
So too much hardens the blood vessels, which that makes the tissue die. So there's not enough blood flow,
Right.
and that leads to diabetic.
Yeah, you need to get the amputation with that. Problems. Vision as well. Just for this purposes here, just remember the signs and symptoms treatment, right? The patients with the very, very high glucose levels, they get into the DKA, the HINC, the other form of that. What will take place is they may start a sodium bicarbonate drip on them. So they drip sodium bicarbonate in IV in order to adjust the pH. Sodium bicarbonate is like a big Tums. It helps adjust the acidity in the blood. Okay. One more thing. I know we went long. You'll never give a patient anything by mouth that has a there we go. Never give a patient anything by mouth that is altered. So if they have the inability to swallow, they have an altered mental status, you would never give them anything by mouth. What you would do is, if they may be hypoglycemic, but they're not altered. They don't have an altered mental status, but they have this sort of the early onset signs of hypoglycemia. You can give them what's called an oral glucose. Okay, you can buy this stuff at Walmart. It's just the class of drug. It is a drug. The class of drug is a carbohydrate. It's sugar paste. Okay, I seen the other day. Somebody had a little thing where you're squeezing the candy in your mouth. That's essentially what this is. Okay, the patient self-administers the oral glucose the way that I give it. If they can't self-administer the oral glucose, then we go a different route. I'm going to give them something. If I administer this to somebody, I could choke them, right? I could squeeze it too hard, get too much in their mouth, and they choke on it, okay? So anybody with an altered mental status, you wouldn't do this. You wouldn't give anybody anything by mouth, NPO, with an altered mental status. Okay, so you'd take this, you'd sort of have the patient put it in their gums, under their tongue, let them absorb that. Right? It would take 5-10 minutes to see the effect. So you give them the oral glucose, and then what would you do? What would be your next treatment? Yeah, recheck a D-stick, because you've already checked the D-stick. That's why you're giving it this, right? So you recheck the D-stick. If they need more, if their D-stick's still up, give them more, right? So it's just sort of this sweet, yucky paste type stuff. In the tube, you need to knead it like a cat, you know, in case it's too thick to shake. So you just do this, try to mix it up, and have them self-administer it. You would give them, they would just take the entire tube. Okay? If the patient is unconscious, okay, then you can't give them anything by mouth, so you would start an IV, okay, and give them D50, dextrose, 50% dextrose, or D50, that's where this comes up from. All right, it's 50% water and 50% dextrose, which is essentially glucose. This will break down very, very quick. Okay, so the body, I mean, it's already sort of in its single cell, so it doesn't take much to break it down or metabolize it. So it breaks down very well. It's sort of like a soda, it's fructose, so it's a lot of sugar molecules connected. It takes longer to break it down. This breaks down very quick. One, because it's given intravenous or IV. So you have the unconscious patient, you would start an IV and give it IV, right? Give it through the IV. It's thick. It's sugar water. It's very thick. So IV wise, we haven't got there yet. We will.
You just put all of that in there?
Yeah, you just give them the whole. It's called an amp. The slang term is an amp of D50. So if they're unconscious, you give them an amp of D50. Okay? This is a lot like Narcan. This is one thing that you probably won't see in the hospital, because they're going to do this pre-hospital. They have that unconscious diabetic patient, okay? If they get to the hospital and they're unconscious with the low D-stick, somebody broke their standard of care. Because they're going to start an IV, they're going to give this to them within a minute, if not faster. That patient's going to wake up. They're going to be A&O times 0 to A&O times 4 within just about a minute or so. And then they'll wake up and go, oh, I forgot to take my insulin, or oh, I forgot to eat, or hey, I've been sick, right? They know they're a diabetic patient, so they're going to know what the problem is. A lot of times those patients are not transported to the hospital. That's why you don't see very many of them in the hospital setting. What you're going to see is the hyperglycemic patient that needs to come in for fluids. So you have someone, because they're excessive urination, they need fluids for the dehydration, so they're going to flood them with fluids. They may need insulin. They may need potassium supplement, okay? They may need sodium bicarbonate. So the hyperglycemic patient, that's the one that you're probably going to see. The hypoglycemic patient is easily fixed. It's like the patient that has overdose on opioids, right? Give them what? Remember that from CPR?
No, it's the
Narcan. You give them Narcan. Narcan wakes them up real quick, makes them really mad. Okay, you just took away their high. So that $10 they just spent for that oxy, you just took it away from them. So in their mind, I guess you owe them $10, but you saved their life. Same way here. You wake them up. They're not really mad. Now they can have, someone that's hypoglycemic can have this sort of bizarre behavior, and they become very violent. All right, they're in a fight or flight mode because their brain doesn't have glucose. It's dying. That's the worst kind of death, really, by the way, is someone that's hypoglycemic, because their cells are dying off. They don't have glucose, right? Anyway, so IV wise, or advanced life support wise, for an unconscious person, you would give them D50. Start the IV, a large IV, again, we'll get into that. You need a bigger IV, diameter IV, because this is so thick, okay? And then once we get into our IV class, we'll talk about the importance of making sure that this goes in the vein and not in the tissue, because it's hyperglycemic, it's hypertonic, and it's going to pull fluid and nutrients out of the tissue. It can actually, if this gets into the tissue, it can cause tissue necrosis. Necrosis would be what? Yeah, so let's say that I put this in the hand or up here and it went into the tissue around, it could actually cause this tissue to die off. So unresponsive, D50, which you probably won't see. You'll hear about it. Just the EMS will bring them in and say, yeah, we gave them an amp of D50. This is what they're talking about. Okay? You definitely wouldn't want that in the tush, huh? Here. Be still. So, or if they're alert enough, you can give them some oral glucose or some sugar paste or something. But for that hyperglycemic patient, IV fluids, flood them with fluids, offset that dehydration. Bicarbonate perhaps. They would have to check acidity levels to see if they're, draw some labs and see if they're acidic. They may need bicarbonate, insulin, right? Definitely probably, the potassium, what they do, they start them on IV potassium, and then they drip some potassium in it to get those levels set back right. Electrolyte levels are very important to maintain. Potassium will affect the heart. Hypokalemia, low decay for kalemia, give you the almost lethal cardiac arrhythmias. Okay, so you gotta protect that. Any questions there? Is everybody good? Okay.